And moving ahead for the last speaker of today, and a person who's very eminent speaker and who doesn't need an introduction, who's a well-known personality to most of us, I think, all over us, beyond India also, is Dr. Neeta Deshpande, who holds a FRCP from Edinburgh, who holds a PG diploma in Anglo from London. He's a certified obesity uh, trainer from USA, person who's the professor and HOD of medicine at Linder College, Belgaum. She's also the associate professor of medicine of the USMKL International Medical Program. She has multiple presentations in obesity and diabetes, and we listening to her, and we always listen to her. And something unique about her presentations, she's always smiling like in a photograph. I've never seen her not smiling in any of her presentations. She has a lot of publications in peer-reviewed journals and textbooks. She has held the position of the chair of Karnataka RSSDI. She is also creator for several clinical trials. She has been the auditor of OKR SSDI in 2016. She is the fellow of RSSDI from 2016. She is also the Edinburgh Fellow from 2016. She has received the Vandana Rambavale Orisha National Award for Obesity India in 2019. She's held the Sam GP Moses Orisha Award from RSSDI in 2021. She's also the coordinator of the consensus group of RSSDI for the clinical practice recommendations for type 2 diabetes and obesity. And recently, we were part of the obesity cross-talk task force talk which she had held a few months back on behalf of RSSDI, where I was one of the invited audience. And it's all, like I said, it's always a pleasure. And she brings her complex subjects to a very simple, basic physiology analysis and makes us very lucid and easy to understand. So over to you, ma'am. A pleasure to listen to you once again. And over to you. Thank you.
Yeah. At the outset, I would like to thank Vaishali Deshmukh and her team for giving this opportunity to me to talk about such an important topic. And that is about the year in review about non-pharmacological or surgical therapies for weight loss and obesity treatment. Well, I'm not going to just do 1 year, but at least 3 years in review because many of the studies are very much connected. So let me start by sharing my screen. So as I said, I'm going to be speaking about non-pharmacological or surgical interventions in obesity, which basically means I'm going to talk mostly about lifestyle modification. I do not have any disclosures for this talk. And the overview would include, of course, all the factors that are included under lifestyle modification. So nutrition, exercise, behavior, whatever I can cover. So I will not be covering, of course, drugs and bariatric surgery. And let us see where we can go from here. So we all know that weight management goals include all of these that you can see, the comorbidities, the quality of life, etc. But to my mind, the most important is to maintain reduced body weight. Because as you will see and as you would have experienced, losing weight is not so very difficult, but maintaining that weight for the patient and preventing further weight regain are the most challenging things in obesity treatment, and that's what we are also going to look at. So all of these are aims in weight management. Let us just delve a little bit into this very elegant models of causal pathways for obesity. As you can see here, you have something called the energy balance model, and the second you have is the carbohydrate insulin model. There are proponents and opposers for both of these models, and both are very interesting, but I will tell you what the commonality is where both these are concerned. So you can see here that the first law of thermodynamics dictates that a positive energy balance must exist as the body energy stores increase. For example, the main dietetic drivers, that is, you eat a lot of food, processed foods, large portion sizes, basically increase your caloric intake and go into a positive energy balance. And because you have positive energy balance, you store fat. The adipose tissue fat storage occurs. So this is what this particular theory says. But there is a second theory, that is the carbohydrate insulin model, that proposes that certain dietary drivers will cause you to actually store adipose tissue. Because of this, there is lesser number of calories available for the body's metabolic needs, because for some reason, because of certain drivers, everything goes and gets stored in the fat tissue. There's less available to the body, and that makes a person actually eat more, and that causes positive energy balance. So you will see here that in this first model, positive energy balance comes first, whereas in the carbohydrate insulin model, the positive energy balance comes afterwards. So these are the two basic differences. Of course, as I said, there are people who believe in and don't believe in either of these. So what it basically means is that the drivers that drive either the energy balance model or the carbohydrate insulin model, both of them target processed carbohydrates as major drivers of obesity. So you may believe in either theory, but the main driver of both of these is processed carbohydrates. So that makes life a little easier for us in terms of treatment. Now, there are difficulties in interpretation of different trials. So it's not very easy to interpret trials of lifestyle modification, dietary restriction, caloric restriction, etc. The reason for this is that even small differences in energy expenditure and macronutrient balance can theoretically lead to significant differences of body weight and composition if the diets are maintained over long periods. You'll find that many of the trials are just for 6 months, 1 year, like that. So it may be very difficult to interpret the changes that have occurred, because 100-calorie difference per day in energy expenditure alone could lead to an initial body fat imbalance of about 10 grams per day. So you need a sustained period of at least 100 days to detect differences in body fat of such kind, and this requires further investigation. The other important thing to understand is that metabolic adaptations to macronutrient changes may require several weeks to months. So the challenges in all these studies and interpretation thereof is that the timing may be too short. Now, let us come to the first and most important tenet of lifestyle modification for obesity treatment. So, the challenges here are many. One is that the manipulation of dietary intake in the aim of influencing obesity outcomes has been the cornerstone of obesity management for centuries, and I'll tell you why that can be fallacious for many, many reasons. So, restriction of energy intake, first and foremost principle, still stands as a first line treatment for obesity, and it is recommended by all scientific societies and dietary guidelines. But it is also true that the evidence from all long-term studies, whatever we have, they indicate only a modest effectiveness at best and a very heterogeneous response. That's why they say one size does not fit all, because the response is very, very heterogeneous. Some may respond, some may not, and there are many factors that influence this. And the most important thing is there is low maintenance of the lost weight when you use lifestyle modification. Everybody knows this. And the extremely high rate of failure to maintain lost weight, which is the biggest challenge, it is estimated to be at more than 80%. And the reason for this is the metabolic adaptation. We all know that there are compensatory mechanisms that defend body weight and maintain the energy stores. So this is the biggest challenge today in obesity treatment. It's not the weight loss per se, it is the weight maintenance, which is the most difficult thing and constitutes the biggest challenge. The other challenges are that there are complexity of diets and multiple influences. So it's not just what you eat. There are behavioral, socio-cultural, community. We have this obesogenic environment today, the food environment, and then the market forces, the agriculture trends, governmental policy matters. All of these are going to affect obesity treatment, and these are the different challenges that we have. So you have so many different kinds of diet patterns, cooking methods, etc., which are all going to influence obesity treatment. And we all know what happens in this homeostatic mechanism. We know that there's a homeostatic mechanism, which is the POMC and the CARTS and the NPY. So we know that the hypothalamus is the seat of homeostatic modulation of what we eat and the satisfaction index. But we also know that these homeostatic mechanisms are very easily overpowered by the hedonic pleasures of eating. And it is these hedonic pleasures of eating that have actually spawned the obesity pandemic, because they so very easily overcome the homeostatic mechanisms which actually tell you that satiety is come about and that you should stop eating. So that is all overcome by this. So this is the other challenge. And this is one of my favorites where weight regain is the rule, as I told you, in some studies, up to the tune of 80%. So you cut down your calories, you increase your activity, but this tug and war continues because your metabolic rate goes down, your hunger hormones go up, and your satiety hormones go down. So this is the saga of weight loss, weight gain, weight regain, again weight loss, and the yo-yo effect is because of this tug of war between what you do and what your hormones do in your body. So there's a constant tussle between that, and this is the metabolic adaptation that we are fighting against, and that is something that you should know. So how do you overcome this metabolic adaptation? So there are different nutritional approaches, different strategies that have been proposed to influence this feedback and try to overcome the metabolic adaptation. So you can see here that all weight loss diets, main important thing is adherence, negative energy balance, and good food. Then comes manipulation of macronutrient diets to try and overcome the metabolic adaptation. So you have low fat, high protein, low carb, all these different kinds of diets. The definitions also can be very, very different. The next thing is nowadays we talk about manipulation of timing. We talk about intermittent fasting and time restricted eating. So you have 5:2, 5 days of normal eating, 2 days of fasting. Then you have alternate day fasting, you have time restricted feeding such as 16, 8, and so on. Some metabolic benefits may be there, but we still require more evidence in human beings. I'm going to show you some studies. It may lead to overeating because of the fasting period that has gone by, and it can have some adverse effects. And I will show you some studies where the weight loss is quite similar to caloric restriction. And the third strategy is to use certain named or dietary patterns. That means it's not just macronutrient that you're changing, but an entire dietary pattern. For example, the Mediterranean pattern or the paleo pattern. So these are some of the things that we talk about. So let's first go to the macronutrient focused approach. That means the carbs, the proteins, and the fat. So basically what you have is low fat, you have low carb diets, and you have high protein diets. These are the famous ones that have been studied more and more, and we have to see how they help us in weight loss and weight maintenance. This is one of the very elegant network meta-analysis of 14 popular named dietary programs. But they fall, if you look at the macronutrients, they fall either into low carb, moderate macronutrients, or low fat. And you can see here that amongst the low carb diets, you have the Atkins, the South Beach, and the Zone. In moderate macronutrients, you have many of them, including Weight Watchers and Mediterranean, which is got a lot of evidence to its name. And you have low fat, which is the Dean Ornish diet mainly. And this is the carbohydrate, the protein, and the fat approximately. And you will find that the moderate macronutrients also have a carbohydrate of 55 to 60%. And the low fat, the carbohydrate content is quite high at 60, and the low carb is less than 40, and sometimes even a little lower than that. And this is the nutrient pattern based diets that you have, and this is the network meta-analysis. And in this network meta-analysis that compared 14 diets, is the same trial that I'm talking about. And the participants, the data, so they actually had 121 RCTs, and they brought it down and they crystallized all the results. But basically, to cut the long story short, what the summary was that Most macronutrient diets over 6 months resulted in modest weight loss and improved blood pressure. And at 12 months, that is at 1 year, weight reduction diminished. We all know that. And blood pressure improvements also largely disappeared. So, this is what this meta analysis talks about. This is again the same meta analysis which goes by the different diets that you have here. And what you see here is that the dark green, the most effective with moderate to high certainty, was the ones here. You can see Atkins, you can see Jenny Craig, and the other lighter green are also somewhat effective. And you will see that the Mediterranean one comes here, the low fat one also comes here, and Atkins also comes here. So, what does that tell you? That basically they are all the same. That means you have DASH diet, which is low fat, which is also in green. You have Atkins diet, which is low carb, again, which is the same. And then you have Weight Watchers, and you have the actual low fat. So all the permutations, combinations are here. You can see, and if you look at the weight loss, then you can see that they are almost all very good for weight loss. And again, the problem is that the definition of low carb is again different. So you have very low, moderate, high, but all the studies that have been done, they have not actually conformed to this exact definition. So that is the challenge in interpreting these trials also. Though there are now, we do have, now this is from the 2023 Diabetologia, and you will find that this is the actual classification. If anyone wants to take up studies, these are the percentages that you should be looking at when you talk about the carbohydrate intake of very low, moderate, or high in terms of percentages and in terms of grams per day of carbohydrate. This is what you should be doing. Now, this is another study just came out about 2 years ago. And this is the typical low carb, high fat diet. So this is like a keto diet. And they looked at the glycemic control and body weight in patients with type 2 diabetes. This was a community-based cohort. It was a retrospective analysis. And they compared glycemic and other metabolic outcomes in patients who had completed more than 3 months. So you had these two groups, low carb, high fat diet, and the second group was just usual standard diabetes care. And the primary outcome that they looked at was the change in A1C because they were type 2 diabetes patients. But they also looked at secondary outcomes in which they looked at body weight, which we are more interested in this particular talk, that is the body mass index. And what they did was in the low carb, high fat diet, the net carbohydrate intake was less than 20 grams per day. So it was actually a keto diet, and protein was 20 to 25% of total calories, and fat was very high, which is a typical keto diet. These were the permitted foods which are permitted in a keto diet, and they were not told to restrict their calories. So it was ad libitum. Only they were told the choices that they could make, and the usual care diet was the usual diabetes diet that we usually prescribe. And this was the result. The result was, now this is in terms of HbA1c, the low carb, high fat, that is this line that you see over here, the dark line, they had an improvement of an A1c with this diet at every visit, as you can see. And at visit 4, the mean A1C was 6.67 compared to 7.8 in the usual care group. And this difference was statistically significant. Now let's go to the weight loss. If you look at the weight loss, the patients on the low carb, high fat keto diet, they lost significantly more weight at each visit compared to the usual care. So the weight loss was really very good. Mean change of minus 12.3 compared with baseline. And the usual care, there was nothing much. So you can see here that both A1C and body weight came down. But I must caution you here, this is a shorter term study that you are seeing. Now comes another trial, diets for weight management, again in adults with type 2 diabetes. So this is an umbrella review of published meta-analysis and systematic review of trials for diabetes remission. Why I have taken this, though it is an obesity talk, is that you know that for diabetes remission, what you require is weight loss. So this was the weight loss and this was the remission rate. So what you see in this trial is that the greatest, this is a very interesting meta-analysis. So the greatest weight loss was with very low calorie diets of 400 to 500 calories for 8 to 12 weeks. So it was 6.6 kgs more than in just a low calorie diet. Just a low calorie diet would be anywhere between 1200 to 1500 calories. This was a VLCD. So there was 6.6 kg more weight loss than in a low calorie diet. Interestingly, meal replacement based diets showed a 2.4 kg greater loss over 12 to 52 weeks, that up to 1 year. So low carb diet was equal to high carb, low fat diets for weight loss. So here goes. So like I showed you in the previous trial. So whether you use a low carb diet, that was a shorter term, this is longer term. So low carb diet was equal to high carb, low fat diets for weight loss. Then if you look at the different other trials like high protein diet, Mediterranean diet, high MUFA diet, vegetarian diet, low GI, all had minimum or no difference from controlled diet. But again, the problem is that some of the studies were low quality studies because of logistic reasons. So we have to take that with a pinch of salt. So, what are the conclusions of or interpretation of this entire network meta-analysis? So, published meta-analysis of hypocaloric diets for weight management in people with type 2 diabetes do not support any particular macronutrient profile or style over others, at least in this meta-analysis. Very low calorie diets and formula meal replacement appear the most effective approaches, generally providing less energy than self administered food based diets. And programs that include a hypocaloric formula, that is total diet replacement induction phase, were most effective for type 2 diabetes remission. This is also this has been seen in Roy Taylor's direct study, so we know about this. Most of the evidence is restricted to 1 year or less in this network meta-analysis. So you need more research, longer term research to look at the durability of all these approaches. So low carb does help, but in the short term, we don't have evidence for very long trials. Meal replacement diets are much better. Total diet replacement much better, at least in the induction phase. And that is what we've seen and we are seeing in this particular thing. Now, let us go to the dietary pattern focus. So that was macronutrients. This was any particular dietary pattern. And in that, I'm going to talk to you only about one because all the data is only with this one. And that is a Mediterranean diet, which is a sustainable lifestyle model because it reduces the risks of all these. And there is evidence for reduction of risk with the Mediterranean diet for all these things, especially obesity, cardiovascular disease, metabolic syndrome, etc. So the dietary model with the largest body of evidence of health benefit is that traditionally followed by inhabitants of some Mediterranean countries. There is evidence confirming the inverse association of adhering to Mediterranean diet with obesity, and 4 meta-analysis of randomized controlled trials, including up to 16 trials, have shown a greater reduction of body weight and BMI with Mediterranean diet compared to other diets, while a meta-analysis of 7 prospective cohort studies found a reduced risk of becoming obese and gaining weight over time associated with adherence to this. So both treatment and prevention of obesity, there is evidence with the Mediterranean diet. So let's put it all together, which has been nicely put by the ACE, where if you look at all the paleo, the low carb, the plant-based and the Mediterranean, and if you have to put it all together, what it basically means is that high fiber, non-starchy vegetables, nuts, seeds, olives, that's for MUFA, avoid added sugars and refined processed grains, fish for pescatarians, eggs for ovo-vegetarians. So if you have to put it all together, there is considerable overlap and these would be the principles. So that is what mainly is telling us. And Mediterranean diet generally limits excessive red meat. In fact, all diets do. So this is, if you put it all together, you will see that there are points of commonality and overlapping, and this would be the common sense diet to give. Well, the future of dietary management in obesity seems to be that you might actually have precision nutrition plate, which basically will depend upon your microbiota, your nutrigenomics, your food behavior and physical activity, everything completely customized to your body, your gut, and your behavior. And this could be the future of dietary management in obesity. And perhaps this will be the holy grail because this might be more durable and sustainable. Now coming to the second part about, so we have completed about macronutrients, we have completed about different dietary patterns. Now the third thing comes is about different timings of eating. And in this, if you look at intermittent fasting and time restricted feeding, I will limit it to what we know in terms of obesity treatment. So in obesity, it is hypothesized that intermittent fasting and time restricted feeding will improve mitochondrial abnormalities in obesity. They would inhibit adipocyte hypertrophy and they would aid in beige fat development, which would be gut microbiota driven because of the intermittent fasting. And it would also aid in reduction of intramuscular fat deposits. So this is what the hypothesis is for intermittent fasting. So if you look at the different patterns, you have alternate day fasting, you have modified intermittent fasting, you have time restricted feeding, which is basically 16/8 that most people follow. And then you have different kinds of religious fast. So this would be the different types of intermittent fasting / time restricted eating. And there are different patterns that can be followed. So I'm going to show you just this one evidence which came out just about a year and a half ago, where intermittent and continuous energy restriction were compared. And if you look at these graphs, you will find that weight loss, absolute energy intake, body composition, and categories of weight loss, there's no statistical significance difference in this in both the diet. That means intermittent fasting and continuous energy restriction result in similar weight loss maintenance, and body composition changes in the 6-month randomized pilot study. So what it would mean is that, is intermittent fasting bad? The answer is no, but it would suit some. So it all depends upon the person's behavioral patterns and what the person can possibly do. So the question that was answered in this particular study was, is intermittent fasting better than continuous energy restriction for adults with overweight and obesity? Well, the existing evidence suggests that intermittent fasting is as effective as continuous energy restriction and may be a feasible and effective approach to weight loss. So, being equal and giving the same kind of result would mean that you have this option to use in people who can actually do it. So if someone is comfortable with intermittent fasting, you can, because it is going to give you the almost similar results. Coming to exercise, there's always a question. We all tell our patients, go for a walk, go for 1 hour, go for 30 minutes, go for 60 minutes. But look at this study where it was an 18-month study. They had 3 arms. One was diet-induced weight loss. Second was weight loss with aerobic training. And the second was weight loss with resistance training. So what they found in this particular study was that weight loss with resistance training better preserved muscle area and improved muscle quality more consistently than just weight loss with aerobic training or weight loss alone. So what's important take home from this slide is that it's very, very important that resistance training, whatever age the patient may be at, whatever is appropriate for that age, resistance training should be introduced to everybody if they are embarking on any kind of weight loss therapy. So that is very, very important. Now, this is a study which was published last year. The effect of exercise training on body composition and inflammatory cytokine levels in overweight and obese individuals. All of you will agree that obesity is an inflammatory condition. There is oxidative stress. So if you can reduce oxidative stress, inflammation, you're going to improve body composition, which means you're going to help in weight loss maintenance as well. So the aim of this study was to compare and rank the effectiveness of aerobic exercise, resistance training, combined aerobic and resistance, and HIIT, and they looked at body composition and inflammatory cytokine levels in overweight and obese individuals in this network meta-analysis. So they took 38 studies which fit the criteria, around 1,300 patients, and what they found was that aerobic exercise did have the greatest effect on weight loss per se, but if you had to do it combined, that means aerobic plus resistance training, it had the greatest effect on weight loss, that is BMI did come down, waist circumference, body fat percentage, interleukin 6 marker of inflammation, tumor necrosis factor marker of inflammation. None could significantly increase the adiponectin level. So this is very important for us, that resistance training with aerobic training extremely important for not just weight loss but for body composition and inflammatory markers. So the current results suggest that combined aerobic and resistance training is the best exercise modality for improving body composition and inflammatory status in overweight and obese individuals. You need more studies for this. Now, this is the effect of lifestyle intervention. I'm talking now combined, that is diet and exercise, on adults with metabolic associated fatty liver disease. Same thing. So this is a systematic review and meta-analysis. 34 studies, 2,600 participants, all of them were obese, obviously. And they did a subgroup analysis on low carb diet, aerobic training, resistance training, and they found that these were the three factors which significantly improved the level of triglycerides, hepatic fat content, HDL, A1C, and HOMA-IR. Low carb diet is more effective in improving hepatic fat content than low fat diet, and resistance training is better than aerobic training in reduction in hepatic fat content and triglycerides. So this is a very new data and good data to tell us the importance of resistance training, low carb diet, etc. Now this is about sleep. This is the screen time usage in hours, and you can see this is American data. We are not far behind, and you can see that increasing screen time affects sleep. And when sleep is affected, these are the things that can happen. Sleep loss can cause high ghrelin levels, low leptin levels, and this will contribute to obesity. So the link between short sleep duration and obesity is real, and we should recommend more sleep to prevent obesity. So stress, we know, is a factor. So this is a study that talks about association of emotional eating with overweight, obesity, depression, anxiety, stress. And this is a review of the current clinical evidence. And what does this review tell us? This review tells us that prolonged stress and depression were both related with greater food intake, with individuals eating at an increased rate throughout stressful periods. And emotional eating appears to influence the kind of food that is eaten, and the food selection is less healthy. And there are several well-designed clinical human studies that support an interrelationship between emotional eating and obesity. So I refer you to this particular publication, which has appeared very recently, just the last month. So are there ways in which you can deal with this kind of depression and anxiety? Yes, you can actually do that. You have yoga-based physical exercise interventions that can be undertaken. And this is just an example that I've given you. And how do these yoga-based physical exercise intervention help? By increasing the mental fitness, reducing stress. So the stress is reduced, anxiety is reduced, depression is reduced. By doing this, you can actually take care of stress. So we've dealt with stress, we've dealt with sleep. All these are very important factors. So the take-home message from this talk would be lifestyle modification in general and diet modalities in particular have modest, effective, and durability in obesity treatment. There is no single diet that is effective, although low carb and meal replacement based strategies seem to have an edge over others. Combined aerobic and resistance training is most effective at all ages for both weight loss and body composition benefits. And sleep and stress are vital factors that need to be addressed. More robust studies are, of course, needed to elucidate the best methods to tackle these issues. So thank you all very much for a patient listening. Thank you very much.
the lucid talk as usual. Covered
Thank
a
you.
complex talk in a very classroom manner, refined manner, and very easy to digest and assimilate and get it. Right.
Thank you.